All right, so this is the endoscopy conference for today. I'm presenting an 83-year-old gentleman with past medical history of diabetes, hypertension, hyperlipidemia, COPD, and angina. We are being consulted for microcytic anemia. The patient came in for an elective cath and found to have a hemoglobin with 6.8 from a baseline of 10 to 11 3 months ago. He had no overt signs of GI bleeding in the past 3 months. And we had set him up for an EGD colonoscopy. I just put the colonoscopy on the first slide because it wasn't terribly interesting and didn't reveal any source of bleeding. These are his endoscopy images. So this is his retroflexed view in the fundus. He has a lot of very nodular mucosa, and some of it looked confluent, and we were wondering whether this was Fundic gland polyps. He also had some areas that looked more heaped, but no specific ulceration or distinct masses aside from the polyps that we could see. The duodenum looked fine. So this was the pathology for this gentleman: gastric fundic gland polyps with focal atypia of the surface epithelium, interpreted as indefinite for dysplasia and negative for H. pylori. He actually underwent a second pathological review at their conference a couple of weeks later, and they had all agreed that this was the finding, indefinite for dysplasia. Okay, so I wanted to talk about fundic gland polyps and two other of the most common gastric polyps. Fundic gland polyps are the most common polyps found on EGD in the Western Hemisphere. Represents about 6% of EGDs and 64% of gastric polyps that are submitted for histology. Usually patients are asymptomatic, and they're described as multiple, small, smooth, glossy, and sessile. On pathology, they're very distinctive. They're dilated oxyntic glands, which you can see here with the big holes in the specimen. They're associated with PPIU, Zollinger-Ellison syndrome, and some polyposis syndromes, FAP, MAP. There's an inverse association with H. pylori, so it seems like if somebody has H. pylori, they're much less likely to have fundic gland polyps. And they very rarely show dysplasia. And in the absence of polyposis syndrome, I've read that they have virtually no potential to progress to cancer. The recommendations are all suggested. There are no specific guidelines because we don't have a lot of good outcome studies. They recommend that, biopsy one or more representative polyps. You can resect polyps that are large, greater than 1 centimeter, or any polyps with suspicious features, ulceration, or those located in the antrum, because that's quite unusual, and that's to rule out dysplasia or neoplasia. You can consider PPI discontinuation in patients with many polyps or those greater than 1 centimeter, and that's been shown to regress fundic gland polyps. There aren't any specific recommendations for follow-up EGDs for fundic gland polyps. Because you can have gastric polyposis with FAP, you should consider FAP if there are lots of polyps, greater than 20 polyps, or polyps in the antrum, onset less than 40 years, or if there are duodenal adenomas on the EGD, and you should go on to perform a colonoscopy in that case. I'm just going to talk about two other of the most common polyp types, just to distinguish them. These are hyperplastic polyps, and that's an inflammatory reaction, proliferation of gastric foveolar cells in response to chronic inflammatory stimulus, associated with gastric mucosal atrophy, such as H. pylori or autoimmune gastritis. They're described as smooth and dome polyps. Sometimes the larger polyps can be pedunculated or lobulated. And the erosion of polyps is very common, and they commonly result in chronic blood loss and iron deficiency anemia. Studies have shown that dysplasia can be found in 1 to 20% of these polyps, and they have an increased risk of malignancy if they're larger in size and if they're pedunculated. So the recommendation is to excise all polyps greater than 1 centimeter, treat any concurrent H. pylori, and then they should go under endoscopic surveillance for atrophic gastritis and GIM. These are gastric adenomas. These are the most common neoplastic polyps. They're still pretty uncommon in the Western Hemisphere. They're less than 1% because of low H. pylori prevalence, but they can represent up to 25% of gastric polyps in East Asia. They have a velvety, lobulated appearance, and they're usually solitary, most commonly found in the antrum. And they're again associated with H. pylori and atrophic gastritis. And many have a synchronous gastric adenocarcinoma. Management recommendation is that all adenomas should be resected. Endoscopic surveillance should be 1 year after resection to look at the resection site and to look for any other new adenomas and to treat H. pylori. So our patient, we were discussing with the advanced team, I think Satish reviewed the case actually, because he has so many polyps and then this pathology report came back as indefinite for dysplasia. He also didn't have any other risk factors for having so many. He's 85. We don't think he has FAP at this point. His colonoscopy was negative. He wasn't actively on a PPI at the time of the endoscopy. So we were not really sure what to do with the dysplasia aspect. We had, I've been, during preparation for this presentation, I've been reading a little bit, and some articles say that some mucosal trauma or regeneration can be mistaken for dysplasia for these Fundic gland polyps, and they don't necessarily represent anything specific, but I just wanted to get your thoughts on the next steps for our patient.
So, you know, you sometimes see this in people who are taking chronic PPIs, and you said he wasn't on it recently, but was he on PPIs, you know, even in the last year or so?
The last prescription I saw for him was in 2017 within our system. He wasn't a fantastic historian, but he told me that he was not on a PPI.
Yeah, because this looks like an FAP type stomach with the multiple polyps, but I have seen this exact picture even with indefinite dysplasia in people on PPI. So that's the first, second, and third thing you should, I would wring his neck and tell him to fess up, you know, about taking PPIs. Was the antrum spared? That's the key. You know, with FAP, the antrum is always spared.
Yes, the antrum, there was no polypus in the antrum.
Okay, doesn't necessarily mean this is FAP. You are right that he's kind of old to be presenting in his 80s with FAP, but there's a rare syndrome that has been recognized in the last few years called GAPS, G-A-P-P-S, which is gastric adenocarcinoma. I forget what it stands for.
Proximal polyposis.
Yeah, and what it is it's a variant of FAP where you only get gastric polyps and no colonic polyps, and you also see gastric cancers. And there's a few families in the whole world that have it. I don't think that's what he has, but it is something that could explain multiple gastric polyps without colonic phenotype. I wouldn't overreact to the indefinite dysplasia. Frankly, even if he had a low-grade dysplasia, I'm not so sure I would freak out in an 83-year-old guy with heart disease.
Sure.
You know, I would do a good family history, make sure that you're not missing any other, you know, polyposis-associated tumors. The biggest concern I have is you haven't explained his anemia.
Yeah, he's gonna undergo a capsule as an aside.
And it's clearly an iron deficiency anemia?
Yeah.
Okay.
Yeah.
Interesting case.
Great case, and thanks for the comments, Steve. Anyone else have any comments or questions for Ji-Yoon? Great. So let's move on to our next case, who I think is going to be Yu Yang presenting.
Yeah. Hopefully you guys can see my slides. This is a case that I scoped on consults with Dr. Mazur a couple months ago. So our case begins with an 81-year-old gentleman. He has a history of advanced metastatic prostate cancer who presented with a few weeks of nausea, vomiting, and diarrhea. He's enrolled in this very interesting clinical trial and for the past 9 months, and I actually had time to go back and look at some of the medications that he was on. So he's on nivolumab, which we all know as an anti-PD-L1. He's also on this novel clinical trial arm that includes something called a FLT3 ligand. It is a ligand that stimulates dendritic cells to become more active and helps them engage and activate T cells. This strategy is also used with radiation, which causes the cancer cells to basically apoptose in a way that attracts the immune system. So these like dying cancer cells release their neoantigens, which then activates the dendritic cells, which then mobilize and activate T cells. And when these activated T cells increase PD-L1 expression, then nivolumab can block these expressions, and it helps this, this combination helps overcome sort of the adaptive resistance mechanism that metastatic prostate cancer can develop. So this gentleman has actually had multiple imaging in a previous scope in the past few months. 4 months prior, he had a push enteroscopy actually for anemia and was found to have multiple non-bleeding AVMs. He also had an unremarkable CT abdomen pelvis 1 month ago. This is just a representative coronal screenshot. So on admission, he had a C. diff and GI PCR, which were checked, which were negative. His ESR and CRP were noted to be non-specifically elevated to 30s and 50s respectively. And this is his CT now on admission, which you can see has distended fluid-filled small bowel. So we decided to perform another push enteroscopy just based on the findings. And because his symptoms have been going on for several weeks, that in discussion with the oncology team felt to be not proportional to something like a viral infectious picture. So this was his push enteroscopy. It was grossly normal. There was some nodular mucosa. This is the duodenal bulb. We went to the midgenome, which actually looks pretty normal, and took some sample biopsies. And the pathology came back with diffuse, moderately active chronic enteritis featuring lymphoplasmic expansion of the lamina propria, intraepithelial lymphocytosis, increased apoptotic bodies. The differential diagnosis for these findings include both drug-associated enteritis and chronic infectious enteritis. Because of his clinical history and in discussion with the oncology team, again, they felt this was less likely to be the remnants or of a viral gastroenteritis picture, and actually more compatible with immune-mediated enterocolitis. I don't know if Dr. Howe is on the line to review some of his pathology about what are the overlapping features perhaps between both infectious enteritis and immune-mediated or drug-associated enteritis.
Yeah, I'm here.
Okay, thank you.
Okay, good morning, everyone. Let me share my screen. Oh, could you, okay. Let me see. Can you see my screen?
Yes.
Okay, perfect. Okay, so this is just show you the microscopic finding in the proximal duodenum. So on the right, I just show you is a normal histology of duodenum. And here is what we found from this patient. And you can see it's dramatically different compared to the normal histology, right? So first, from top to the deeper level, we'll see first thing we see is the blending of the villus. You see, in the normal, usually we see the very nice villus, but here is mostly almost totally blending. And then we'll see damage of the epithelial cells. And also there's some increased intraepithelial lymphocytosis. We'll take a closer look. And also you see all the glands and the crypts also kind of damaged. And let's move to the lamina propria. You see here in the normal histology, all the glands is regularly, uniformly displaced. But here you see this expansion of this lamina propria by the neutrophils and lymphoplasma cells. And let's take a closer look. And here we can better appreciate all these changes. So there's some lymphoplasmacytic infiltration in the epithelia, and also we see this expansion of the lamina propria by the neutrophils, lymphoplasma cells, and sometimes we can see these neutrophils infiltrating into the crypts, or call this cryptitis, and even this crypt abscess. And here this crypt is damaged, and we call this withering. And here you can see the increased apoptotic bodies here, here, and here. And this is a proximal duodenum. Similar thing we saw in the duodenal bulb, you see here. But let's go back to see another important feature I didn't mention. Compared to the normal histology, you see in the crypt of the gland, there's a lot of goblet cells and also has the Peyronie cells, right? But you didn't see here. All the goblet cells and the Peyronie cells is depleted. So this is a kind of a feature of autoimmune enteritis. And let's move to the jejunum. Again, similar thing, blending of the villi and the expansion of the lamina propria, and infiltrated by the neutrophils and lymphoplasma cells, and also damage of the crypts. And again, you see the goblet cells and the Peyronie cells is almost totally gone. Maybe only 1-2 goblet cells left there. So again, this is a mimic to the autoimmune enteropathy. So that's why we put this this line here. We says this resemblance to autoimmune enteritis. Consider patient's history of the checkpoint inhibitor. It could be induced by the checkpoint inhibitor. But all these findings is non-specific, so we need to rule out others like a CMV infection, but it is negative, and also the like Dr. Law said, the GI PCR are negative. So it's more likely it's the checkpoint inhibitor induced. Yeah, that's it. Do you have any question?
No, that was great. Thank you so much for going over the key features on pathology.
You're welcome.
Mediated enterocolitis. Hang on 1 second. I'm gonna share my screen again. Okay. Can everyone see my screen back? Okay, great. So in terms of this gentleman's management clinical course, so before the biopsies came back, he was actually discharged. And then when the findings came back, he was recalled to the emergency room and started on high dose steroids with recurrence when he had like recurrence in his symptoms. So he actually, as an outpatient, had his steroids tapered, then developed diarrhea again. So the prednisone were bumped up. He unfortunately just missed a GI appointment with us, but the plan is to consider some biologics given his non-response to steroids. So thought I would talk briefly about immune-mediated enterocolitis, which is an entity as gastroenterologists that we are seeing more and more of, especially in the advent of immune checkpoint inhibitor therapies. So just as a brief background, For immune checkpoint inhibitors, increase T cell activity and the anti-tumor immune response, but also have immune-related adverse effects that affect the GI tract. In terms of the adverse events in the GI tract specifically, it's seen in about 7 to 30% of patients on immune checkpoint inhibitors, depending on the class of immune checkpoint inhibitors used. Specifically for anti-PD-L1, including nivolumab, the time to onset, which is a little bit unusual in this case, is usually between 2 to 4 months. This guy was like 9 months out, so it was a little bit more unusual, but certainly still possible. In terms of the type of GI immune adverse effects that you can see acute colitis, microscopic colitis, upper GI tract inflammation, and also pseudo-obstruction, with acute colitis being the most common. And obviously, you have to rule out other things, important differential diagnoses, such as infection, neoplasia, radiation enteritis, and self-limited diarrhea. And importantly, the reason that diagnosis is so important is because the recurrence risk when re-challenged with anti-PD-L1 and specifically is about 12 to 30%. So that's why the oncologists a lot of times will push us, rightfully so, to perform an endoscopy to make this diagnosis because it determines whether or not they can continue with the therapies. So I picked this article in CGH about management of patients with immune checkpoint inhibitor-induced enterocolitis. So there have been 4 consensus guidelines that have been developed on the management of immune-related adverse effects. They are purely based on case series and mostly retrospective. So there is certainly a need for stronger evidence-based data to inform our clinical decision-making, but this is the best that we have currently. This is the algorithm that I thought was the most helpful in the article. So 40% of patients with diarrhea on anti-PD-L1 monotherapy actually have normal endoscopic findings. But when we consider sort of the diagnosis, once you've ruled out infection, like we did in our gentleman, CMV, which, you know, a serum PCR doesn't necessarily correlate with potential findings on endoscopy, and other viral etiologies like HIV, HBV, and the patient has grade 2 or higher diarrhea, then an endoscopic evaluation should be considered. When present, in, you know, again, in 40% of patients, they might not have endoscopic findings. You can see erythema, luminal bleeding, erosions, and ulcerations, usually in a patchy distribution. This is just a brief chart on sort of the grading. So anyone with grade 2 or diarrhea or above, which is increase of stools, 4 to 6 bowel movements over their baseline, should be considered for an endoscopy. And in patients with grades 2 to 4 diarrhea, they should discontinue their immune checkpoint inhibitor and receive systemic high-dose corticosteroids, either orally or intravenously, according to the severity of diarrhea. Patients who respond to IV corticosteroids should be switched to oral form. This is kind of like an almost like an IPD type regimen. And then basically can be considered, if they are responding, to do a taper, which is what our gentleman ended up receiving. If they somehow do not respond to the taper or they relapse, then they should be referred in conjunction with the oncologist and the gastroenterologist for consideration of biologics, including Remicade, and also vedolizumab. In terms of patients' response rates to infliximab and vedolizumab, so 1/3 to 1/2 of patients with immune checkpoint colitis end up requiring a second-line treatment with infliximab, and the number of fusions that they end up receiving is not, every month like you would in an IBD patient, but typically just 3 infusions. So my take-home points are that immune checkpoint inhibitor-induced enterocolitis is common and something we should definitely keep in our differential in any patient on immune checkpoint inhibitor, even if they are out of the typical time frame that we would expect. Endoscopy should be performed early in patients with grade 2 diarrhea or higher after ruling out infection. The treatment after you make the diagnosis are withholding the immune checkpoint inhibitor and also high dose steroids. If there's no response to steroids or a relapse, then patients should be considered for infliximab or vedolizumab. And I would love to hear sort of people's experience on treating immune checkpoint inhibitor colitis with a biologic. And we'll try to make sure this gentleman follows back up in GI clinics so we can have those discussions.
So it's a very interesting case. I recently had a patient who was on a checkpoint inhibitor and developed pancreatitis. She was kind of having low-grade pain. She had elevated pancreatic enzymes, and a PET scan showed that her pancreas was there was diffuse uptake. So it wasn't like the kind of pancreatitis where she was admitted to the hospital, but she was uncomfortable. And we saw her and we did an endoscopic ultrasound and biopsy, and it was read as autoimmune pancreatitis, which we attributed to the checkpoint inhibitor that she was on. I forget which one it was. Anyway, she responded to steroids, and more and more you start seeing some of these cases, at least with pancreatitis, coming out in the literature. And what I've seen is that classic autoimmune pancreatitis, so all these things are responsive to steroids, as your case was. Classic autoimmune pancreatitis, if it's refractory to steroids, it's typically treated with Rituxan, which acts against B cells. I think what's interesting in what you're showing is that these checkpoint inhibitor mediated inflammatory conditions seem to be T cell related. The lymphoplasmacytic infiltrate is still there, but I think it's just interesting that it's more T cell related rather than B cell related. And I guess you're not giving Rituxan, you're giving, I guess, agents that are more active against T cells. I don't know if any of the I don't know if Saurabh's on, or if anyone else has any insight into the immunology of these.
Yeah, I don't have much insight into the immunology, but it's surprising how few of these patients we actually do see, because the oncologists largely, they just grab steroids, they treat. If that doesn't work, they have no hesitation with treating with infliximab. But unlike us in IBD, they will use infliximab in the short term, which we typically would never do in an IBD patient who has a chronic condition. So that's a different use of the agent. And as far as vedolizumab goes, because that's very specific for inhibiting trafficking to the gut. For those who are on checkpoint inhibitors and have, GI tract cancers, there is some question about whether you're diminishing the efficacy of the chemotherapy when you give vedolizumab, where the effects of the immune effects of the checkpoint inhibitor might be diminished in some way, but I don't think anyone has studied that very well.
Bruce, correct me if I'm wrong about this, but isn't it true that for checkpoint inhibitor colitis, when we give the infliximab, it's usually high dose and the response is pretty quick? And if they don't respond within 48 hours, we should be giving them another dose. And I remember a patient like this at clinic also who had the same issue, but unfortunately the patient had a perforation afterwards.
Yeah, as I said, we are rarely asked to manage the infliximab, but it's not unusual for them to use high dosing.
It's funny you say that, Bruce, that they're very, they're quick to sort of stop, they institute the immunologic and then stop it quickly. It was the same experience I had. When we have a patient with classic autoimmune pancreatitis, we're pretty meticulous about making sure they get a 1-month course of prednisone at 40 milligrams. We do a very slow taper because we know there's a significant relapse rate. And the oncology team just totally took over the care. They put the patient on steroids for like a week or so and started tapering it. And it made me very uncomfortable. But like you said, they're just used to dealing with this. And I don't know if there's any long-term outcomes or sequela of these short courses, but at least from the pancreatitis standpoint, this patient behaved differently than your typical autoimmune pancreatitis. And actually just saw her this week. She's doing great. But yeah, I think it's just interesting. It's they have their own sort of algorithm for this, as was shown.
Yeah, different world.
Great case. And I think a year ago, one of our former fellows, David Fallick, gave a grand rounds on checkpoint inhibitor colitis. He sees, I think, a fair bit at Memorial Sloan Kettering. Any other last minute questions, comments for Yu Ying's case? Okay, if not, we'll turn it over to our advanced endoscopy fellow, Nick, for his case.
All right, thank you. In a very different vein, I have a more procedurally oriented case here. This is Zenker's case, and we performed a Zenker's per oral endoscopic myotomy, which I'll present. So the patient was 75, history of hypertension. He has had a chronic cough for a long time, which he, just kind of wrote off. But then in the last 6 months started developing more like regurgitation of undigested food, globus sensation. And so he sought more of a workup, and he was found to have a pretty sizable Zenker's, 4.7 centimeters. This is not his Zenker's because it was done at an outside facility, but this is a representative esophagram showing a large Zenker's. And before we jump right into the endoscopy, I'm just going to explain a little bit about what a Zenker is so everyone has an idea of what they're looking at, because the endoscopy can be a little disorienting. Essentially what the Zenker's is an outpouching of this weak area of the pharynx called Killian's triangle. It's right above the cricopharyngeus muscle, and it's a false diverticulum. So it's only mucosa and submucosa. And you can see on the right an image of where it is. It's posterior. This is what it's going to look like endoscopically. This is sort of a schematic view, but essentially when you enter the esophagus, you see the esophageal lumen. There's a septum and then the diverticular lumen. And below you can see what it looks like here. So the goal of this procedure is to actually, in this case, enter that septum and perform a myotomy of the cricopharyngeal muscle within the septum. And that allows the Zenker's to sort of flow better and reduce the symptoms. So we're gonna watch a video here. So just to orient everyone, the esophagus is on the right, the septum is in the middle, what we're looking at right now. And then this is the Zenker's with some food particles in there. So again, what we're gonna do is try to enter this septum, perform a myotomy of the cricopharyngeal muscle, and that'll relieve the symptoms of the Zenker's. So the first step is a submucosal injection, and then a mucosal incision with an electrosurgical knife here. And it's a very tight working space, as you can see. So it's a lot of manipulating angles, rotating, and not damaging the surrounding mucosa. Once this mucosal incision is created, a tunnel is created similar to a typical poem. And it's an alternating series of injection of just saline and methylene blue to expand the space, and then dissection with the electrosurgical knife. And this is all with the goal of exposing that muscular septum, which you're actually starting to see there. So again, that septum's in the middle. That was a tunnel on the diverticular side, and now we're creating a tunnel on the esophageal side to carve out the muscle in the middle in order to allow us to dissect that safely. And all of this, again, is with the goal in any of these submucosal procedures, POEM, Z-POEM, you really want to preserve the mucosa, because ultimately that is what prevents you from having a full thickness perforation, because we are dissecting all the submucosa, we're dissecting out the muscle. And so the only thing preventing you from being full thickness is that mucosal layer there, and ultimately closed clips. The other big enemy of this procedure is bleeding. So anytime we identify a big vessel, as here, we prophylactically cauterize it. So this is pretty much the end of the tunneling. On the left, this is a tunnel adjacent to the muscle on the diverticular side. The muscle's on the right there. And then on the right side is another tunnel on the esophageal side. So we've successfully isolated the cricopharyngeal muscle right in the middle. And that's this big bar, vertical bar right in the middle. And now that it's all dissected out, it's actually fairly simple to do the myotomy. Again, it's just an electrosurgical knife, and you just cut your way down all the way to the bottom of the Zenkers. And this muscle is very thick. That's sort of the part of the pathophysiology of the Zenkers, is that something, either the tight cricopharyngeal muscle, potentially esophageal motility, is creating a high pressure zone above that cricopharyngeal muscle, which creates the outpouching. So if we can eliminate this high pressure from this very thick muscle here, then we're treating the Zenkers. So this is the myotomy continued. Again, very thick muscle layer. And this is all the way down to the bottom. So you can see the muscle, which was very thick, is now essentially obliterated. We have the meeting, sort of joining of the two tunnels. We had a tunnel on the right, tunnel on the left. Now it's just one tunnel with a sort of mucosal septum. So after having that very thick bar in the middle, we now have the Zenkers, and you can see the blue going all the way to the bottom, indicating we tunneled down to the bottom of the Zenkers. Then this very thin septum, you can clearly see the difference now. And on the right, the esophageal lumen is preserved with no mucosal damage there. Now the next goal is to just close that incision, which is closed with clips. And that's just zippered up with 5 clips, which stay in place. And just a final check that there's no mucosal trauma here. The esophageal lumen's still open. And that's the clip closure there. And that is it. So the patients we usually admit them for 1 day, get an esophagram the next day to confirm that there's no leak. On the esophagram, you can see there's still a little persistent Zenkers. Of course, this is only 1 day out, but he's discharged after this. And then 1 month later, he has complete resolution of all those new GI symptoms, the regurgitation, globus. His chronic cough improved a bit, although it was still present. So this case is pretty unique. Zenker's pretty rare. We'll talk a little bit about the treatment. For asymptomatic patients with the small Zenkers, observation's appropriate. And then if they're symptomatic and they have a large Zenkers, there's a few options. Open neck dissection was the traditional way of treating this, which is a large surgery. The surgeons also do rigid endoscopic therapy. And now more and more flexible endoscopic therapy performed by a gastroenterologist is being done And there's even 2 ways within flexible endoscopy to do it. So we just looked at the Z poem, but you can also just do a septotomy, which is essentially, instead of carefully dissecting out the muscle in a tunneling fashion, you just cut the septum through. If there are some trials comparing open surgical repair to endoscopic repair, although most of the trials are done in the surgery literature and they compare surgical repair to rigid endoscopy. The main take-home point is that surgical repair has lower recurrence, although it's more morbid. And you can see some of the potential complications, including fistulas, recurrent laryngeal nerve palsies, bleeding, and also a longer length of stay, which you might expect. This particular approach, the Z poem, is a newer approach. There are not randomized trials comparing the 2 approaches, and there are some larger case series. So this is one of the largest case series. Technical success was very high. Adverse events, 7%, was comparable to what we just looked at in the last study with rigid endoscopy. And most of these are not very severe comparing to those long-lasting complications potentially we saw, like recurrent laryngeal nerve palsy. These are often intraprocedural, such as bleeding or a perforation, which can be closed endoscopically. And in 12-month follow-up, there was only 1 recurrence. So there's definitely potential for this approach. There's a thought that it is more durable than the other method of doing a septotomy with endoscopy, but more data is needed. Thank you.
Yeah, that was a great presentation, Nick. This case, if I remember, we had a couple in a row that week. Yeah. I think it took about an hour or so to do. One of the other things in terms of deciding between the 2 techniques is that with the Zenker's poem, it's controlled cutting of the muscle layer within a tunnel. So you can cut as far down, and if you cut a little bit too far, it's okay because you close up the mucosal incision. With the traditional flexible endoscopic septotomy, if you cut too far, then you've got a perforation to deal with. So you can get a little bit more aggressive with the Z poem technique. It doesn't really take significantly longer. You're talking about an hour-long procedure. And the data that you showed open versus endoscopic, that was the rigid endoscopy. And for the rigid endoscopy, the ENT docs have to basically really hyperextend the neck and then insert almost blindly this sort of stapling device that one sort of duckbill of the stapler has to get wedged into the diverticular side, and the other duckbill side has to get wedged into the esophageal side, and they close it down and staple and cut. But the distal tips of that device doesn't have any stapling or cutting, so they always leave a little bit of diverticulum behind, which is why traditionally the ENT docs wouldn't do this if someone's diverticulum was a centimeter or less, because they wouldn't be able to completely cut and divide that septal muscle. But it's a really nice presentation of a good technique. It is a tough working space because it's really high up, usually in between 15 to 18 centimeters from the incisor. So sort of an unstable position, but we have been able to develop this really safe technique taken from poem tunneling.
Nick, it was a nice presentation, but you rarely see 2 lumens when you put the scope down. You only fall right into the Zenker's diverticulum, and that's a real problem with people that don't guide their scope down visually, because you end up in the Zenker's all the time, and the orifice that goes 2 ways, one in the Zenker's and one in the esophagus, is only seen at the very upper extent of the Zenker's diverticulum. You can't get out of a Zenker's diverticulum once you're in the bottom of it. You have to pull the scope back to the very top, and then you can see the two lumens. But usually the scope enters the Zenker's all the time.
Yeah, that's a good point. Luckily, we knew what to expect, but it's a good argument for very carefully intubating the esophagus every time, because you never know what you're going to find.
Great. Any other last minute comments or questions before we turn it over to our grade round speaker? Great. Thanks, everyone.